Welcome back to the Queer as See Me podcast. I'm really excited to have Dr. Luke Allen on today. And Luke, I would love to let you give a short intro so we all know who you are.
Sure. So I'm a licensed psychologist, geographically located in Las Vegas, Nevada, also licensed in California and Oregon. Psychologists have this thing. So basically, I can see clients in almost all states, but like seven-ish. Most of my work centers on LGBTQ plus youth, but primarily more on trans and non-binary clients. Been doing more work on OCD and body focused repetitive behavior over the last couple of years too. I use he, him pronouns. And just as like kind of a disclaimer or more information, I'm not trans. I don't have lived experience. Most of my experience and knowledge comes from research, professional leadership roles, clinical work with clients, and relationship with family and friends and people who identify as trans or non-binary.
Yeah. I was just curious. You mentioned having some lived experience being in community and relationship with trans folks. Do you want to share?
Sorry, sometimes like my mouth runs faster than my brain and then
Yeah.
parts get left out. So I came out as the label identifier I was using when I came out as gay when I was 18. I feel like queer, bisexual, or might be slightly more accurate. And then it wasn't really until then that I got involved in LGBTQ spaces and like receive support from friends on the broader spectrum. So I don't have lived experience of being trans or non-binary. Most of my experience comes from relationships with family and friends and colleagues and through clinical work and research.
Yeah. And I think it's really important though, because there is a difference. Like there's a difference in all these lenses of lived experience, right? In all these lenses of experience, and they all have value in, different ways. And I think, there are a lot of like cis allied clinicians who will work with trans and gender diverse patients who don't know any other trans or gender diverse people outside of like their clinical work, right? And so again, I still think like being in community with trans and gender diverse people gives a different lens than not, even when we don't have lived experience as trans ourselves. Yeah.
Yeah, I would agree with that.
Yeah. I think just like I'm gonna derail us before we even start talking about your work, which if you've ever listened to my podcast, you're used to. But
Yeah.
I just think like I think the ways in which I was taught like Western medicine and like colonizer medicine, right, is to have such a separation from like provider and patient, right? Like I wasn't taught a lot. Like I was taught not to self-disclose. I was taught, you know, I wasn't taught how to be in relationship with my patients other than to be their provider. I wasn't taught how to like run into them at the movies or, run into them at the gas station or be in the same church with them. Right. Those weren't things that were like really taught. And I think one of the losses because of that approach is that like there can be a loss of humanization of my patients from the other clinician when I'm not actively working to be in community with them outside of the clinical space. And I think that's such an important element to all healthcare that like we both recognize like we're two humans in a room together.
Yeah, I think that goes a long way. This is, I guess, since you're going to derail us, I'll derail us even further. There's kind of like this model. It's more like a descriptive model and like philosophy and ethics. And you probably might have heard of it before, but we have these moral circles of like, people immediately in our life who we care most about our family, nuclear family, and then like our community, neighborhood, and like, I don't know, our state or, all these other identities we have and like far off, people in different countries and animals and like, I don't know, I think what you're talking about might tap in a little bit to more like once we're like, we can expand our moral circle. We can kind of like, it's once we do that and we see them like humanize them more, it's easier to have empathy and compassion and understanding. And if it's really clinical and distant and like can't share anything about yourself, and here's just like a medical problem to be solved, I think, yeah, you kind of lose maybe that like human aspect a little bit.
Yeah. And I think it's made it so much easier for me to be like transparent about when I don't know things. Right. Like, because I don't feel so separated from my community, I don't feel like I have to have all the answers.
Yeah.
Yeah. Which, as a like medical provider, is something that I got through school by having all the answers. Right. Uh,
I guess
Yeah.
maybe this is too like spicy or tongue in cheek, but I guess I feel like oftentimes, like in many situations, I feel like the people with like a lot of high certainty and confidence, it's like those end up being the people that you should kind of like trust less. It's
Yeah.
like, yeah, and like time and time again, I see that over and over.
Right. Yeah. I think like being in community with the communities we serve is so essential for healthcare workers to like, yeah, maintain that sense of humanity for all of us. So I love to hear that about part of your story. And you mentioned you do clinical work and some of the focus of your clinical work, but we actually connected over this recent article you have in the Journal of Pediatrics or Adolescent Medicine.
Journal of Pediatrics.
Yeah, yeah. And so Luke was sharing that he helped co-author this paper called The Changes in Suicidality Among Transgender Adolescents Following Hormone Therapy and Extended Study. And I was really excited to see your paper come across our shared spaces. And I would love our wider audience, maybe not in those shared spaces with us, to have some exposure to your work and what you were looking into and what you found. I would love if you let our listeners
Would
in.
like a short version or a long version?
Let's start with the short version and then we'll get juicy.
Okay. The short version is this is essentially a replication study of my dissertation, much larger sample size, and consistent results of, hey, look, after hormone therapy for trans and non-binary youth, we found again that suicidality significantly decreased just with like a larger sample size and larger observation window.
Amazing. Yeah. Are you, well, this is like, I feel like a very juicy question. And it's okay if either one of us know the answers. We were actually talking before we started recording about how we're learning publicly together and that means we're going to make public mistakes together and how I think that's like really important to name, particularly when this work feels so life or death right now.
Mhm.
Right. With like the current political climate and like what is happening to trans healthcare and access to trans healthcare, everything has like a sense of urgency and importance. And I feel like that makes it even more uncomfortable for me as a clinician to like potentially say something incorrect or to make a
Mhm.
mistake or to learn something in public. So I think naming that to be true maybe makes it a little gentler for both of us.
That is something that I experience quite frequently. Like that, yeah, that fear of saying something wrong, it being interpreted in a way I didn't want, saying something but like forgetting the context or nuance that I meant to add. Yeah, yeah. I appreciate you saying that. Yeah.
Absolutely. I think we're all living in that space. And I often think of it as like a marker of like, I mean, one, right, obviously that to some degree is tied to like white supremacy that we're all trying to like unpack and unwind, but that's like a lifelong journey. And two, I think it's also like connected to caring. Right. And so I think that's really important. But yeah, I'm curious, uh, like, are you aware of any studies that show like an increase, like a worsening of suicidality after access to gender affirming care in trans adolescents?
A really good question. I guess I'll give you sort of the long version with some analogies along the way. So if you look at like even like our frontline treatments, I'm a psychologist, mental health treatment, that's my field. If you look at like frontline treatments for OCD or panic disorder or things like that, the best thing we have in the toolbox, the most effective thing we have is exposure and response prevention. Even with that, 50, 60% of people like improve, get better. A small portion of people stay the same, and like a small portion get worse. So once we're talking like large numbers, like I'm not sure if there's anything out there where some people aren't going to get worse for a variety of reasons. From my understanding of literature, I think you and Jack Turbane, I think, have a good list on your websites about like all the studies to date. Mine might be like the 22nd-ish, where it's like looking at like outcomes and data and youth who receive medical treatments. Basically, none of those show harm, at least none of it was detected in like the measures we were using in these studies. And like overwhelmingly, the consistent result is people improve, or at least they improve compared to now they're looking more on these measures, like what same age, peers look like. So I'm not aware of any, and actually this, I guess I'll continue. You can stop me when you want.
Yeah.
But I think so I have a background in ethics. I have a degree in philosophy. I didn't mention it before. I'm also co-chair of the WPATH Ethics Committee. And so all my views are my own, by the way. I'm responsible for everything I say. But like everything is so politicized nowadays, like incredibly so. And research gets weaponized all the time. And so sometimes what happens is you'll have a study that's published where the one I'm thinking of in particular, looked at gender confirmation surgeries, like outcomes afterwards, and it's behind a paywall, and the abstract says something along the lines of, "Oh, people who receive surgeries are no worse or no better off." The takeaway from that study was actually, people are way better off from baseline. They're not better; they're about the same as the general population now. The takeaway was people improved, and then you have studies like that just like get taken and weaponized and used. And so I think if there's like this perception of harm, it's usually coming from like this intentional or unintentional misrepresentation. And part of that I think is unavoidable, like regardless of the field. There's also this translation problem in science where it's like, how do we take this jargony, nuanced stuff, all these statistical analyses and like caveats, and like translate that to something that you can read in like a CNN headline or whatever. So there's a problem there. So my guess is like a lot of the perception of harms is usually coming from, if you go down this rabbit hole, the study there probably doesn't support it. And at the same time, like anything, like the goal of medicine isn't to prevent regret. Like if that was the case, we'd stop breast augmentations for cisgender people because like 51% report some degree of like mild regret, So I'm almost done here, I promise. I think there's a problem like in evidence-based medicine. There's kind of a distinction between, does this thing work and is it working for you? And so what the data show is like, yeah, people improve. Population averages, large numbers, like what we see is people get better over time. And then it's a very different case of like, oh, is this venture going to be right for you? I really liked your 2-part series with like the dosing question. Like that's a perfect case of like, there are these risks and benefits, and like, how does it align with your goals? And I don't think you can do the evidence-based medicine without drawing out like that individual care and like what's the patient's values, because the data is never gonna answer the question of like, should you give this medication? Like you can't answer that without understanding the patient's values and how they're weighing things. Does that answer your question a little bit? Sorry.
No, I think that was a great answer. And it was like full of so many like really thoughtful and like thorough responses. I think, my understanding of the literature today is like very similar as well, that like really most of the studies we have looking at adolescent gender affirming care show general improvement. And then there have been a few studies that just like don't show harm specifically, but don't show like an improvement. Right. And those are overall, there's like those studies are less and smaller than the ones showing the improvement, but those do exist as well. And I think it's really, really important to remember how like there is a misinformation campaign happening currently. So like, yes, things can absolutely be taken out of context, which is so easy to do with research.
Yeah.
I think even as someone who was like trained in how to read like scientific research and literature, right? And to not do that, to not take things out of context, and to remember like, correlation versus causality, and remember all these things. I still sometimes like have to circle back to all of that.
There's not anyone I know that's been like quoted or cited, even in the academic literature or more generally by reporters, where it's like, yeah, everyone gets like misquoted, or there's like a lack of representation, even from people who are trying to do well. And so it is a huge, huge problem. With those studies that didn't show improvement, or like, people didn't get worse, but they didn't really get better, I think some of those probably have to do with like puberty blockers. And I like maybe that was even one of my studies too, where it's like back then we're thinking, oh, so puberty blocker might help with distress and like all these things. But like actually, I mean, the theory, once you think about it a little bit more, like the theoretical rationale for that sometimes is preventing future distress, not resolving current distress. And so some of these things, it's like, I wonder the things that they're saying where progress wasn't noted, improvements wasn't noticed. Some of those might come down to these things. Well, like, oh, maybe we shouldn't have expected that in the first place.
Actually, I will pause you there because I think that's very representative of what I see clinically. Is when I'm working with people who are doing puberty blockers alone without like any hormone therapy on top of them, oftentimes it is because like we're coming in earlier in their pubertal process. So like oftentimes like there isn't a big change in how they feel because they weren't having, they were starting to have some
Yeah.
dysphoria and they were starting to have some distress, like, but it was early. We weren't, 3 years into puberty and their voice has dropped and, they like have facial hair and they can't look in the mirror every day. And so I do think hearing you talk about that, there's an interesting correlation to what I see clinically. Like a lot of times, yeah, uh, adolescents are like, yeah, I feel the same.
Yeah. Yeah. And I guess, it's true. I'm glad like your clinical practice, like, no, like you see that too. At least I'm not like just making up things in my head. But there's lots of criticisms we had about like the state of science, and we have like this whole replication crisis, or like there's even this like theory crisis in psychotherapy, and there's problems like statistical analyses and like p-hacking, and what analysis do you use, and like, well, does something make it over that 0.05, statistical analysis p-value? But I think once you realize, like, I don't know, so science isn't just one study. There's not like one study that's going to definitively ever like answer everything. And I think once you zoom out, that's like, oh, there's a trend here. Yeah, we have all these limitations, but study after study, different groups of people doing it, different measures doing it. Generally speaking, people are improving. Even if there was a 100% certain like counterfactual world, like thought experiment, we're in a world where gender-affirming interventions for youth is just really helpful. It's just like random variation. Like you're gonna have some studies and different like error that mix into it, where like you're gonna get different results if you do something over and over just because natural variation, you know. And so we would expect some of those studies. We might even expect some studies that show a little bit of harm, depending on what measures they use. I'm not sure how medicine does in general with measuring harms overall, but like I don't think we can answer this question with one single study. It's kind of looking at everything together. Once you look at everything together, it's pretty clear. We have reason to believe and lots of evidence and study after study showing benefit.
Right. And I think that, right, that goes back to like both like taking a step back and a more holistic view and like looking at the entirety of the evidence to identify trends, like is is so important. And it's getting so hard to do in like our current society where like we are flooded with information and so much of it is actually like misinformation and disinformation. And so like I feel like that can be incredibly challenging and it's like just an important part of um for all of us. Oh, I would think of Trust It or Trash It, which is like a website you can check out other
Oh,
websites at to see if they're authoritative sources. But I'm also in perimenopause, so I just a lot of times lose what I'm looking for. And the one I was just looking for was like when we're trying to like understand if something is misinformation or disinformation or propaganda, it's so essential that we're looking at this bigger picture and this larger context, but that we're also like really interrogating the like training experience and like values of the authors.
mm,
There's this like weird, I feel like, I don't know if this is true in like psychology research, but I feel like in science research, there's sometimes this weird like, and I feel like this is in journalism too, like where we don't do values-based writing. Like our writing and our research is not supposed to be influenced by our values. And I think that's just,
um,
humans can't function like that.
yeah,
Like we
yeah.
can't actually do
I mean,
that. Anyway,
mhm. Yeah,
we cause
it's
more harm by
yeah,
trying to decide for that than not just like being really transparent about, I think,
yeah,
what our actual,
yeah,
um,
yeah, exactly. That's definitely the case in psychotherapy, psychology research. I'm not a psychoanalyst and don't want to be, but like even Freud, like you patients on the chair, on the couch, face up, not even looking at you. You're kind of trying. You're actually like spending 6 months trying to understand them and their history and their worldview, and you're like this kind of blank slate, and you're kind of striving for this like objectivity. But like, like later theorists, and that's a little bit rusty now, but maybe even Freud himself, it's like, no, you need your own experiences, you need your own values. Like that's how you can connect. That's how you can understand the client. So kind of what you're talking about before, maybe humanize with them. And it's like, it's not a problem. It's something that can kind of be like utilized clinically or scientifically in some cases when evaluating bias. It's like a bird wishing there wasn't any air, but you kind of need the air to really make progress. Like you can't fly without it.
yeah, I think so much of my work right now and so much of what I'm doing is like so rooted in being in community that like it's probably going to like be a recurring theme. But I do think it's so essential when we're talking about this, like, well, yes, like look at the literature, look at the like trend, and then like evaluate the authority and intentions of the authors and investigators. And then also like listen to community, right? Because there is so much community wisdom. And I think it's always like when I'm reading, you know, I'll read a book, I'll go to someone else's talk in gender affirming care, or I'll read a book about a subject that, I have a lot of thoughts about. And I think you said it earlier, like I'm not just making things up in my head. There's something still reassuring to me as a practicing clinician when I interact with another clinician's work, right? And we've like created similar practice adaptations to meet the needs of our community because it's like we are seeing the same themes and there are like a certain number of tools we have to like respond to those things. Like I'm not stating it very well, but I think again, when the trend in research and literature says gender affirming care reduces thoughts of suicidal ideation in trans adolescents and youth. And then like the community also says that there is like this,
Yeah.
what's the word when two things agree?
Convergence, like agreement, concordance,
Yeah.
alignment.
Yes.
Yeah.
All these words are great. Which like again, it feels like we have more information informing us. We have a larger trend, and that can be important. And I have a question. I'm just curious what you think practicing clinicians, like both, because we mostly have prescribers as our target audience. So I'm
Mhm.
curious, like what you would want prescribing clinicians to like take from your research and from your body of work, and particularly this article. If there's anything that like you feel like they should adapt into their practice or
So maybe I'll try to comment on what you were saying, and then I'll come back to this. And so I wonder if part of what you were getting at earlier is we just like listen to the community and the people who are receiving the care. Like I sometimes worry, like, oh, like people read my study and they're like, oh, well, duh, because like it's something they already know, they see every day. And so like, is it really anything new? And so I think for some people, like, yeah, this is like just telling me what I already knew. Of course, political climates, very politicized, research is weaponized, etc. And so for some people, like actually, I don't think it's everyone regrets it, and people get more suicidal afterwards. And so I think this might not give much information to the people who do this every day and do good clinical work and kind of take a holistic, individualized approach. But then I think hopefully, maybe it'll move the needle a little bit more on the more evidence side debates and just like whatever our certainty was before, we should have a little bit more certainty now. So in terms of what should I think, I guess I'll answer the second question and your question in a different way. One of some of the things that stood out to me about this study was actually most people like aren't coming in like highly distressed or suicidal. I think there's this perception sometimes, at least when I talk to some parents or people or like read certain like memes from certain groups, it's like you would think everyone is like distressed and awful and like, being trans is psychopathological. Like, no, like most people in this study were coming in fine. Most of my clients, LGBTQ plus and trans and non-binary, most are coming in and usually they're fine, or they're coming into things completely unrelated to being trans. So one I think a good takeaway is kind of like also reinforcing the narrative, like not everyone's in distress. There's many ways to be trans, many ways to experience dysphoria or not experience dysphoria or incongruence and still be trans. But for those that are coming in either distressed or reporting suicidal thoughts, dramatic increase in suicidality. I didn't report it in this way in the study, but like the relative risk reduction. So anyone coming in reporting any suicidality dropped by like 2/3, like 65 point something percent, which is huge. And then of the people who reported, people coming in reporting recent suicide attempts, that dropped by like 85%. So of those people coming in, like huge, huge, huge drops. I think the difficulty with some of this research too is like suicide or completed suicides, like it is such a low frequency behavior. Like we measure these things in like hundreds of thousands, but just like there was no way that I could run the analysis or make any like analytical decision that would like obscure that. If it took out outliers, like the results were the same. There's some behind the scenes things you can do to address this distributional properties of the data. You transform it, results are the same. You do one, not the other, results are the same. The results are the same from the 2019 study. And so I'd say the thing though is I'd maybe harken back to, does something work and does it work for you? There's no one size fits all. Again, would encourage listeners to maybe listen to the two-part podcast on
I love the
dosing.
promo. Thank you.
Yeah, it's not uncommon for me to see parents of youth, either minors or young adults, and they tell me, "Oh, you're the third, fourth, fifth provider I found," but they stopped or didn't go back to the other providers because they kind of like they for whatever reason they kind of walked away feeling like guilted or shamed or kind of their impression of the provider was an advocate. And so I think, especially when it comes with youth, like unless you can engage or help the parents feel understood, I don't know, sometimes we might risk doing harm to the child if they're not going to get care after all. And so I think sometimes that's like the hardest part of like, how do you work with the entire system in a way where you recognize the urgency or distress or dysphoria of the child, and then also the fears and concerns and of parents. And like some, like just based upon like headlines and what I read, like sometimes I don't blame parents just because like I see why people might be coming from a place of a lot of fear.
Yeah, I think I just want to take a moment to like acknowledge that what you're saying is like one of the things you found in your research is that like trans people are thriving, right? And I do think there is such a tendency, there's such a tendency for just like traditional media to focus on suffering, particularly in any group that doesn't have liberation. And so that messaging can really hyper focus on trans people not thriving and on the increased suicidal ideation amongst trans and gender diverse folk. I think it's really important to remember that like that is not all of our story. That is only part of our story, and that you're seeing that in your research and literature. And I think it's such an essential thing to remember. And I also find myself sometimes when I'm interacting with parents who are, because of the political moment, so worried about loss of care for their young people, and then so worried about their young people dying by suicide because of loss of care. I think sometimes what you're saying, going back to the individual, your research is specifically about accessing medical intervention for gender affirmation, but we have lots of studies also showing that like a supportive adult and consistent use of names and pronouns, right, is like incredibly protective for trans adolescents' mental health. And then, like, when we're thinking as individuals, like, right, because again, you're talking about populations and looking at all of this data. When we're talking about individuals, like, has this has this person ever, had thoughts of suicide in the past? If they ever had suicide attempts in the past, has anyone in the family died by suicide? Like, for my parents who are worrying, where are actual risk factors right now for this, your individual young person, not just like what you're seeing in the media and the literature. And then I think also recognizing that, like, and this is like a slight side conversation to what we're having. We don't need to go down this road very far, but also recognizing that, like, trans people have existed since humans have existed and have found ways to thrive all of this time. And a lot of us do live with like chronic SI, right? And it doesn't necessarily mean we're not going to have like full, happy, wonderful lives either. And so I I think sometimes again the fear prevents us from having like more grounded and rooted and nuanced conversations about this. And it's like, okay, this is scary. This is very, very scary. We definitely want your young person to grow into adulthood. And I feel like that's sometimes like the primary job of a parent, right? Is like to keep them alive until they're adult. Um, and right, how can we de-escalate ourselves to have like nuanced conversations about this to like really understand and to like so that it continues to feel like a space that is safe to talk about this? Because if your young person sees you being so afraid, then they're also going to be worried about worsening your anxiety and fear. And so then they might not feel safe talking to you if they are actually feeling unsafe. Right. And so I think we've gotten a little bit into the clinical bits of things, but you were bringing in like working with whole systems and like families as systems is what I was thinking when you said that. And I think it's just so important to remember like, yeah, that like the most capitalism and white supremacy and colonialism have individualized us to such a high degree and isolated us to such a high degree. And when we start losing access to the things that we thought they gave us, right? Healthcare, the way forward is in connection and in relationship. And so we really have to be able to have those kind of conversations with our young people as the adults in their lives. Like, there's research that shows like you're going to be higher risk for suicide. And that makes me feel like afraid and sad. Like, how do we as a family want to like move forward and talk about this? And like, what are things you find supportive? I sometimes like forget just how helpful it is to ask my adolescent patients what they need. I don't know
Mhm.
if that's like a common adult thing, but when they're like, oh, I don't want to do the one-on-one video visit time with you today. And we're like, okay, what would help make that more accessible to you next time we
Mhm.
speak? And they're like, oh, I just want to be in a different room in my house. And I'm like, okay, great. You're full of great ideas. Let's do that. Thank you so much.
Yeah. No, there was so much there. I'm not sure if I'm going to be able to respond to, but I guess the most recent thing you said, yeah, I think oftentimes it's like, ooh, I think people internalize a lot of things, for lack of a better word, like what's wrong with me, why do I feel this way, like why I'm so depressed, anxious, etc. And it's like it's such a like sort of like trivial, silly example, but like sometimes like when you change environments or the people around you, or like the most people who are really successful at like reducing smoking and drinking, they change their environment. They don't go to the same places. They reduce temptation, and so like, sometimes the solutions are, it's not fixing a problem inside of us. It's kind of like creating an environment that's more supportive or that helps meet our goals more. And like that's a very behavioral approach. Like, okay, like what can we do? What's objective that can like help us make progress on this thing? And yeah, you found it out pretty quickly for that patient, it seems. And then I like all your
Yeah.
other points too. Yeah, trans people are thriving. Definite, yeah, for sure. Too.
Yeah, absolutely. I love that part that you take a moment to highlight that when you're talking about what you saw doing your research for your publication. And I think that just that you also took time to say we looked at the data, we looked at it in many different ways, and and we're still consistently seeing reductions in suicidal thoughts and suicidal attempts for adolescents accessing gender affirming care. And I think that's, yeah, I don't know how many of the people who don't already do this will listen to this podcast, but I think it's such an important message, even for the ones who have been doing this right now, because I feel like one of the issues that like I have with so many of my colleagues so often is when we like run into ban states and like, we're seeing more international bans as well now, is like the solution a lot of my colleagues want to use is like moving adolescents for care, getting them to environments where it's safe. They don't want to continue care in the current physical location. And it like I've had a lot of problems with this from all along, because that really only the most resourced families can do that, right? Like, and there have been a lot of phenomenal organizations helping support families with like, funding and travel support. But still, like if you have other kids at home or you don't get PTO from your job, or right, like you just
Not it. Mhm.
it's not accessible, right? It's not sustainable. And I think there's this idea that like, well, I'm not doing a thing, so I'm not like the problem, right? Because like it's not like, I'm gonna use a really intense analogy, but right, it is not like that prescriber, that clinician is not, doing experimental surgery on a Black slave without their consent, right? They're not taking an action on someone's body,
Yeah.
right? Or they're not the like, physician in Germany walking people like
Yeah.
running the gas chambers, right? They're not taking an action on someone's body that's causing harm. And so it feels like there's less responsibility for the harm that is going to be caused by the lack of access to care.
Yeah.
And I think that's where I just ethically disagree with most of my colleagues.
Yeah. Yeah. No,
And I
I
think,
hear.
and I know we have to like watch out for like causality and correct,
Mhm.
and all of that. But I think again, the trend in the literature that we're talking about
Yeah.
shows that not providing gender affirming care to adolescents when they are appropriate for it causes an increased risk of harm.
Yeah. I would say there's a lot there, and a lot I want to talk about. Yeah, I'd say so. guess in like a research lens. But so yeah, our study is not like an RCT. We don't have a control sample, but like a strength of our study is like there's a lot of ecological validity. Like this is like real world data from a clinic, seeing real world client, like patients, and some criticisms or like things you'll read from, again, what I probably argue often like anti-trans sources is like, oh, well, like maybe improvements came from therapy or all these other things. But like, so what's the suggestion there? Is it like we should like withhold therapy from people? Also, like standards of care is like you're giving recommendations. If you think someone could benefit from other treatments, you're treating the whole person. I'd say like the most cautious, most critical person, I think even they might have to take away something like this. Like, well, we have no evidence of like no reason, no evidence to think it's harmful for like the most skeptical person. And then if you zoom out and you look at it again with all the research, actually, well, relative risk reduction of 2/3 to 85% reported decrease suicidality. So yeah, we have a lot of reason to go the other, like strong arguments to make the other way. With I wonder, as you were talking, I don't think you did. It's more just like a kind of like a self plug. There was one of my first articles I wrote. It was in the Journal of Theoretical and Philosophical Psychology. There was an issue I disagreed with all my colleagues with, and like it really annoyed me and frustrated me. So going back to like values and like professional ethics, like what's happened over the last decade or two or more, it's like organizations are saying, hey, look, our work goes beyond just the one-on-one interaction, laying the hands on person, treating someone. And now if you look at more and more codes of ethics, we have this social justice responsibility, like, ethical guiding principle. And so, advocacy or supporting, overall human well-being, and and every organization has their own issue. American Heart Organization, cares about cardiovascular health. But if we have this larger responsibility, then we have to think about how does that change how we think about our ethics of things. So I fully admit I place a super high value on autonomy, maybe even to a fault sometimes. There's nuance and around like what you mean by autonomy, if you're kind of like thinking of like a more like historical, philosophical perspective or legal, like autonomy is a negative, right? Like it doesn't say what you can do. It says like people shouldn't do certain things to you. But I was annoyed of like when it came around drug prohibition. And like, we say in the room, we're like, okay, we're not telling people how to live their lives. We're not imposing our own values on them. We're trying to help them make informed like decisions based on kind of their values, their life, what they care about. And then almost everyone I would talk to is like, oh, well, we can't legalize cannabis. We can't, make safer access to other drugs. We have to like ban these things. And I make the argument in this paper, 2018 paper, 2019 paper, where it's like if we looked at like drug prohibition policies from the like we do a clinical trial, we would have stopped this a long time ago because we have decades of it not working. Things are getting worse. Where's the benefit? And like what we do here domestically in the United States, like we export our values in other countries, like we withhold foreign aid. And so, things happen like, well, okay, Bolivia, we're not going to give you funding unless you, destroy all these crops. And like coca leaves are like huge cultural piece of, some people's like heritage there for them. And so I think there's many ways where it's like, okay, if we're going to say our ethics and values, we have to think more broadly than almost every westernized like education model and like organization kind of like really upholds autonomy and beneficence and just non-maleficence. So what does it mean if we say, okay, we're going to try and not violate autonomy or restrict people from what they can do, but then you're going to turn around and then support some policy. And so I don't know, it's kind of yeah, it's a tangent, but yeah, I think if we're going to accept we have a larger responsibility of society, then we have to think about how our principles and values, what does that change for us?
Absolutely. We were definitely going to link the changes in suicidality paper in the show notes, but I would also love to link the other paper you're referencing. And absolutely, my work prior to trans healthcare was working in substance use disorder treatment. So, yeah, fascinating world and subject. And I often think really rooted in like all of the skills I use in gender affirming care were the skills I used in substance use disorder care, and also the skills I used in hospice. That was the work I did primarily before that as well, which center autonomy. Maybe all fits the fuck, quite intensely. And yeah, I think I think it's so important that so much of like the response to like the 26 state ban, and how many states have active bans? I can never quite keep up with it. I think it's somewhere between 25 and 28. Two of them are surgical.
This thing
The
here
rest
was at
of them are,
27-ish.
yeah,
Yeah.
yeah.
Yeah. The most
Uh,
recent one would have been New Hampshire, I think.
yeah, yeah. And I know there are local on the ground clinicians doing amazing work. I'm not in any way trying to like diminish the importance of the work that has happened. And I think as we see more state bans pass, as we see a non-supportive federal administration, as we see international bans pass, like there are not going to be safe places to send youth to access care. And so like this question of am I participating in this unethical like restriction of care, I think becomes more like more value centered, like more rooted
Mhm.
in like what is my framework for how I approach human rights and how I approach my healthcare practice. Because like I feel like there has been with the state bans, there has been some ability to like postpone that really intense and simple examination because like there have been potentially like other potential routes for adolescents to access care that felt accessible enough to clinicians that they didn't have to feel complicit in the genocide of a generation of trans adolescents by not providing care. And I think we're at the beginning of seeing that part of this experience shift to where, again, like moving adolescents to other areas for care is going to
Mhm.
become less and less accessible.
Yeah.
And so then we do have to really do this intense
Yeah.
examination.
I will say from the I agree. I think on most all points. I think from and by the way, I don't think I mentioned it already, but like I super admire like the work you did to protect patients' like privacy with like the demands for records and like I don't know places who give up records too soon. I don't know, like maybe their patient should sue them for that. This is protected. Yeah, they have a right, and so I think you did the right thing there. And so you might know more, have a different perspective. But when I kind of go to like meetings or talks from ACLU or other trans advocacy organizations, I think like what those experts say is like, okay, well, like all the states that probably are going to ban it probably like already have, and then with the exception of New Hampshire, but like then they did, and so I could be naive, but also hopeful that maybe at least with like straight out bans like it's gonna largely look how like might not get too much worse than what it is already. Fingers crossed.
Yes, I someone always has to bring the optimism and hope. So I'm
Well,
really glad you are holding that for us today. I sometimes don't hold it well. And Miriam Cobb is one of like my favorite thinkers, and she's the person who is quoted all the time for saying hope is a discipline. But yeah, I think the tactics are changing. Like, right, like yes, maybe we won't see more state bans and like like you referenced the DOJ subpoena that we received and that we went to court over, like they are using alternative tactics. And those tactics are again rooted in like scaring clinicians and harassing clinicians and attacking funding. Like there are all these other tactics
yeah.
that are coming. And I think all of them, whether it's a straight out ban or not, are going to reduce the number of places providing adolescent gender affirming care. And I think, again, you can hold the hope for everyone, and also maybe be the um, uh, kind. You can play the like good parent. We're parents in this analogy, and I can play the bad parent. And I'm like, think about what you did. And again, I want to hold space for like all of the clinicians who are listening. Like, this is a place where like we learn, and I want us to learn and grow together. And I know I've been a person who has said things very strongly in very many spaces and very pointedly in very many spaces. And that happens. I say those things because I am feeling so intensely
Mhm.
afraid for
Yeah.
my community and so deeply like, you know, all of my partners are trans, like all of my chosen family is trans, right? Like everyone like most of the people I have like loving, deep, intimate relationships in this world with are trans. And so when when my colleagues are saying like, what can I do? Like, what am I legally allowed to do? Not like, how do we organize to resist this in a way that like allows access to like ongoing care,
Yeah.
I get very upset. And so that I say things very pointedly. And I am personally working very hard. All of our listeners can hold me to this. I'm personally working very hard on like naming that feeling that I'm having in the moment before I say the very pointed thing, so that maybe I can invite listeners into a space of vulnerability with me, which I don't love Brene Brown's work, but might help us all stay on the same team a little bit more. Because, like, again, resistance is in relationship and in community. And so,
Yeah.
um, I've like derailed us. I'll let you talk.
Okay, let me see if I can remember to respond to everything. So yeah, I think you have a fair point. Obviously, it's like, okay, well, even if there aren't any more bans, well, there's like this kind of like legal warfare where it's like they're kind of using sort of like scare tactics or draining your resources. And I know like it wasn't easy for you to like fund or organize the effort to defend against like the presumably like unlawful like DOJ requests, which like a judge sided with you, so like it was like unlawful. Like that's hard. That takes a lot of effort and energy, and that scares people from providing care. Like even years ago, I heard like clinicians in states where there were bans who were identified, who identified as trans and non-binary themselves, like out of fear, just like decided to not even see trans minor clients anymore. And so even if there's not a ban, yeah, it's definitely accessing availability to care. And then there were already wait lists. On one side of the spectrum, people think, kids are coming in, like, well, and we're never giving drugs or medical interventions to kids, like it's only adolescents, and just by like definition, really. And we're like rubbing, stamping, and giving drugs right away, where it's like that's so far from reality. Like I'm sure there's exceptions as there is with everything, but it's like, well, no, you have to like meet with so many providers, and you have to like wait to even get your first appointment, and then you have to like get a letter or an evaluation, and then like figure out insurance and go through the endocrinologist. And so like my point is like care was already like hard to access, and here's a systematically undervalued population who is affected by the restricting access to care, which is totally a double standard, because the quality of evidence that we have for gender care is like that's just the default. Like most healthcare, most research, most interventions aren't high quality, and that there's nothing new. There's nothing new there. And people had to make decisions all the time about like risk and uncertainty, whether it's like cancer treatments or blood transfusions or new pharmaceuticals. And like almost like all decisions are based with some degree of uncertainty. And so even if there's not bans, here's this targeted effort like towards restricting access to care. And that affects usually like the poorest of the poor, usually like the most under-resourced people. And maybe sure there's not any bans, but Congress could withdraw funding for like all state funded plans, and then that's going to affect people more. And now people are scared, even if there's not like a legitimate legal risk, people are scared into like not providing care, and that still affects people. Like I guess that's not like an optimism note, but just validating part of what you're saying.
Yeah. Yeah. And I think it's like, again, I understand where so many of our colleagues are, but I think, again, hearing Luke's research makes me like really grounded in the fact that like this is life-saving healthcare that we're talking about, which like I think maybe you and I would have like a whole different conversation about like this is healthcare rooted in autonomy, and that's like how I want all healthcare to be. And so, but I find that sometimes that's not as motivational for some of my maybe some of our other audience. So like, look, this is life-saving healthcare, and like not offering it is like akin to not offering insulin when someone has type 1 diabetes, right? Like this is like a thing that like in other components of healthcare, like we wouldn't, like as clinicians, we might have more intensity of a response to a restriction over our prescribing practices. But because it has been like, you know, talked about as a moral issue,
Mhm.
we have like a very different approach to it. Because I think sometimes I hear from colleagues like, well, not everyone could do what you did, like about the way I've run my practice or the choices I've made. And it's like, I'm actually not that exceptional. Like I trust me, I wish I was. Like my ego tells me that I am. Right? But in
Well,
reality, like I'm just a human doing
well,
human things. And
yeah.
the reason I could do it though, right? The reason I could like start my own practice, the reason I could like base my like care decisions on my values, and the reason like I could be in resistance to the subpoena was because I have a huge support network,
Hmm.
right? Like I had set myself up over like years, to just be like supported by so many people. And that's both like personal community and colleagues. And I think that's like where a lot of people are like, well, I couldn't do what you did. And I'm like, it's like I didn't do it alone. And like when you see it, you just see me sitting there talking about it and you don't see, right, the night I got the subpoena, like three of my closest community came over and like a safety and security expert came over and like spent all night with me. So I was not alone.
Yeah, I can build on a little bit of what you said. Yeah, I don't know, like after certain elections or dates or court cases happen, sometimes like people are so distraught and like loss of hope and despair and like suicidality too. But after like a certain person was or was not voted in or a certain decision was made or not made, like your community, like all the people that still loved you yesterday, still love you today. All the supports you had are still there for you. If we when we look at like societal progress over like decades and centuries, like is it really like the government's there leading charge, making things better, or they're like it's really the community making changes, and then there's a critical point or tipping point, and then that's later reflected down the road and legislation and policy, and so one day or one decision didn't change all the support and love and yeah support you had along the way. And what's different about like at least as opposed like compared to other civil rights progressions, LGBTQ plus rights have like a vast like advanced so rapidly. And like I don't know, like in one lens, you might expect some backlash because like we've made so much progress. And so like even the backlash, if you zoom out, you take a large enough view, like that can also be a sign of progress. And it's
Yeah,
just like hard, in the meantime.
I absolutely try to remind myself of that like broader view lens of like history when I think about like yes, like you know, after the 60s and 70s, there was the 80s.
Yeah, yeah,
uh, and Reagan's war on drugs, which we referenced earlier.
yeah.
So absolutely like that pendulum swinging. It does feel, I wasn't well, I was alive in the 80s, but I was like unaware of what was happening on a like scale. I was like learning to walk. But the severity of wealth inequality that has just like progressed in the stage of capitalism, I think, and then the climate crisis. Let's just like pull every possible important thought into this one episode of the podcast today, right? I think just this swing of the pendulum feel possibly more intense, or maybe it's just like I'm more alive. But yeah, I
Yeah.
think that's a good reminder.
Maybe trying, what was it? I can't remember exactly what you said, but like hope is like a learned skill or like
Hope is
refine
a discipline. Yeah.
is a
Very
discipline, is a discipline.
impactful.
Yeah, you have to like practice and it's hard and you lose sight of it. You have to keep going back to it and back to it. And like habit change, like changing things and changing your perspective is really hard. We'll say I heard once before, I can't remember who said it, so I apologize for the lack of contribution, but everyone before us had even more reasons to give up and stop fighting or going forward. And I think even if we're not doing anything like that would be called activism or progress, just like living your life, being happy, like having it like not being drained, like contributing positively, even in small ways to the people around you, like that is progress. If we look at probably one of the best theories we have for like what contributes to like social change and civil rights is contact theory. And people like we were going to talk about before, we need to see trans people thriving. And like it's harder to see them as like, oh, your whatever negative view you want to add there. And even just living can be an act of resistance as well. I know that's a famous quote, wasn't trying to say.
Absolutely. Absolutely. I have taken enough of your time. Thank you so much. I feel like we could continue this conversation for like 5 more hours, but I'm going to let you get back to your life. Thank you so much for the research you've added to the field and how important and useful that is for both our medical community and like the trans community as a whole, and particularly our trans adolescents. And thank you for the work you do every day with your clients as well. Cause like both are so important, both that larger view that we've talked about so many times, stepping back and taking, but also that individualized care. And I love hearing you talk about both of them.
Thank you. I appreciate the opportunity to talk to you and your audience. And I'll talk to you later.